What additional function does the thyroid gland have? Huh?
Production of calcitonin.
No, I mean in terms of يعني, related to the thyroid hormone, not to the calcitonin. Related to T3 and T4, I mean.
It synthesizes the hormone and then secretes it.
Yes, exactly. Synthesis and storage and secretion. So in thyroiditis, there is disruption of the thyroid follicles. They rupture. So they liberate all the stored thyroid hormone into the circulation. This is why there is an initial phase of hyperthyroidism or thyrotoxicosis, let me say. Okay? Type. Even if you don't give the patient any treatment whatsoever, after some time, the thyrotoxicosis will go away. Why is that? Who can tell me?
The gland is destroyed and there is no more production
Yes,
after the release of the
yes,
stored hormone.
and more importantly, the T4 is not unlimited. It has a half-life of 1 week. So after 1 week, 10 days, all the T4 that is liberated into the circulation will be broken down. So the patient will return being euthyroid. The next thing that happens in thyroiditis is that there is regeneration of the disrupted thyroid follicles. So if the regeneration is not adequate to accommodate the patient's metabolic needs, the patient will develop hypothyroidism. Okay? So a very important function of thyroid follicles is also what uptake of radioiodine, not only radioiodine, uptake of iodine, because the building blocks of thyroid hormones are tyrosine amino acid and iodine, right? So if in thyroiditis there is poor iodine uptake, whether the normal iodine we take in the diet or in water or in food, or the radioactive iodine administered in the radioactive iodine uptake. Is it clear? So this is why, like here in the slide, can you see my slide?
Yes.
Okay. Is it in slideshow?
Slideshow.
Okay. This is why in thyroiditis you see this picture, reduced thyroid uptake. And this is diagnostic for thyroiditis. Okay, is it clear?
Yes.
Okay, great. So this concludes last time's lecture. Let me start by today's presentation. Just tell me, please, once you see my slides, okay? Can you see my slides?
Yes.
Okay.
In slideshow.
Okay, moving or fixed?
Moving.
Great. Okay. So the intended learning outcomes of today's session are the following. By the end of today's session, you will be able to list the symptoms and signs of hyperparathyroidism. You will be able to understand the various imaging modalities in hyperparathyroidism, namely plain X-rays, ultrasound, CT, MRI, and technetium sestami B scan, another scintigraphy. And you will be able to detect the clinical presentations of hypoparathyroidism, whether acute or chronic. And you will be able to list the signs of hypoparathyroidism. And you're going to be able to enumerate the investigations of hypoparathyroidism. And you are going to understand some conditions mimicking similar yani to hypoparathyroidism, namely pseudo-hypoparathyroidism and pseudo-hypoparathyroidism. Don't get confused. I'm going to explain everything. Okay? Now, hyperparathyroidism. On this slide, you can see all the clinical manifestations of primary hyperparathyroidism. Usually, the patient has general aches and pains with pseudogout and chondrocalcinosis, some bone cysts and brown tumors, proximal myopathy, polyuria, renal calculi and nephrocalcinosis, constipation, abdominal pain, chronic pancreatitis even, and calculi, dyspepsia, hypertension, osteoclastomas of the jaw. I will show you how they look like. Anorexia, nausea, vomiting, thirst, some corneal calcifications, okay? And there may be evidence of pituitary tumor if it is part of multiple endocrine neoplasia type 1, or if it is part of multiple endocrine neoplasia type 2A, there will be in addition medullary thyroid carcinoma. So this is a summary of the clinical manifestations of primary hyperparathyroidism. All right? This is actually band keratopathy. You see, the cornea is subdivided like a watch, okay? Here is 9 o'clock, and here is 3 o'clock. If you look closely, there is a white band spanning from 9 o'clock to 3 o'clock. This is the typical band keratopathy seen in advanced corneal calcification. But early, you cannot detect band keratopathy except by doing slit lamp examination like that. The illuminated arc here, illuminating the eye, is the light of the slit lamp at the ophthalmology department. And you see the white specks, these are the corneal calcifications or band keratopathy early. All right? Can you see my slides? Is it visible what I'm talking about?
Yes.
Okay.
Yes, doctor, it's clear.
Okay. Now coming to the investigations of hyperparathyroidism. First of all, we do radiology, okay? Not first of all, because as I mentioned last time, in endocrinology, the first investigations you request are the biochemical or the chemistry. Serum calcium, the serum organic phosphorus, alkaline phosphatase, and the PTH, right? And then you do the radiology, okay? In the radiology, we can do plain X-ray on bones, revealing generalized osteopenia up to osteoporosis. I'm going to show you pictures. Loss of lamina dura. I'm going to show you again a picture. Subperiosteal bone erosions, typical. Bone cysts and brown tumors, very important. Osteitis fibrosa cystica. This is seen mainly in secondary hyperparathyroidism, in secondary and tertiary, and calcification of soft tissues. So this is an intraoral periapical radiograph showing. This is the normal lamina dura, like in all of us. You see, the tooth is attached to the bony alveolar margin, right? And if you look closely, there is a white line. This white line, well circumscribed, is the lamina dura. This is the same picture in a patient with primary hyperparathyroidism. You see the bone is almost eroded, completely eroded. And where is this white line? As if it's erased completely. So this is complete loss of the lamina dura. Is it clear?
Yes.
Okay.
Yes.
Okay. Now, this is and whenever a good advice for you, whenever you see a radiology, an imaging modality, don't rush and tell about the pathology that is present. Take your time. Just describe what you see. So this is a plain X-ray of the left hand of a patient with hyperparathyroidism, primary hyperparathyroidism. So showing what? There is subperiosteal bone resorption, particularly visible in the radial margin of the middle and ring fingers in the middle phalanx. You see? Okay? And in addition, there is also acrosteolysis. There is osteolysis of the acral part of the distal phalanx or phalanges, as if they are eroded. Can you see? They are eroded. Let me show you another picture. This is a plain X-ray of the right hand of a patient with primary hyperparathyroidism, again showing subperiosteal bone resorption. You see here, there, and starting here as well, okay, with phalangeal tuft resorption, okay? The terminal phalanx is as if it's eaten away. All right. And this is what gives actually a clinical picture of pseudo clubbing. Pseudo written P-S-E-U-D-O. So primary hyperparathyroidism can be considered as one of the endocrine causes of clubbing. Okay. The other cause was what that we discussed last time. Who remembers?
Graves.
Yes, thyroid acropathy, Graves' disease. Excellent. Okay. All right. And this is again a plain X-ray of the hand of a child. How do we know it is a child? Who can tell me? Huh? Who can tell me? How do I know it's a plain X-ray of a child?
الفيزياء البليت
Yes, exactly. The epiphyses are still open, you see? There is cartilage here, there, here, there, here, and there. All right? Here, actually, there is extensive subperiosteal bone resorption in the radial and in the ulnar margins of the middle phalanges of these three fingers. Very extensive. Okay? So this is how subperiosteal bone resorption looks like. Before treatment, you see it's eaten up. But here, after treatment, a nice white line like that. Can you see the difference?
Yeah.
Okay. Okay, and this is a plain X-ray skull, lateral view, showing the typical salt and pepper skull. What is salt and pepper skull? You see here the white areas represent the normal bone. Bone on plain X-ray appears white. And the dark areas, the eroded dark areas, are the areas representing the bone that is eaten away. So it looks like as if you have put some salt and pepper on a plate. It looks exactly like that. Okay? And so this is the salt and pepper skull before treatment and after treatment. The texture, notice the texture of the skull vault, how it looks like. Even. Here it is evenly white, while here it is intermingled with the eroded black areas. All right? Now, I told you about brown tumors. Okay? They are, the word tumor actually doesn't mean that it is a malignant tumor. No, tumor in Latin means swelling. Okay? So this represents a brown tumor. This is a plain X-ray of the right hand of a patient showing a brown tumor in the middle phalanx of the index finger, of the right index finger. Okay? And in addition, there is extensive subperiosteal bone resorption until the little finger with phalangeal tuft resorption, extensive, including the thumb as well, and osteopenia. You notice that the bone density is less than normal. Okay? Just by using a technique called DEXA scan or dual energy X-ray absorptiometry, you can distinguish between osteopenia and osteoporosis. But here on plain X-ray, the radiologist will only be able to tell you osteopenia, okay, meaning decreased bone mineral density, okay? It's not possible to diagnose osteoporosis by plain X-ray, okay? And here is a plain X-ray of the left hand of a patient with primary hyperparathyroidism showing bone cysts. Here, there, 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 and there. So what is the difference between a brown tumor and a bone cyst? Did you notice the difference? Can somebody tell me? What is the difference? Is there any difference or are both the same? Huh? Can you hear me?
Yes, doctor, we can
Yes,
hear
we can
you,
hear you.
but I don't know.
Type, you don't know. You see here in the brown tumor, but this one is too small to be able to appreciate. There is, if you look closely, as if there are new structures inside the so-called cyst. It's not a cyst, okay? These structures are pathological bone, newly formed pathological bone. But here in the bone cyst, as if it's an area devoid of bone. You have taken away the bone. كأنك بتقورها بالمقورة يعني. Okay? So let me show you another plain X-ray of the left hip joint of a patient with primary hyperparathyroidism. And here you can notice that this is the head of the femur, the neck, the greater trochanter, the lesser trochanter, the shaft, and this is the acetabulum, okay? And this is the pubic bone, okay? Here you see the arrow points at a brown tumor. You see the brown tumor here, you can notice that it is expanded, an expanded bony lesion, but it's not devoid of structures. If you look closely, there are attempts at new bone formation inside, like appearing like eggshell, okay? This is the typical X-ray finding of a brown tumor. Is it clear?
Yes, doctor.
Yes.
Okay, okay. So, let me tell you about chondrocalcinosis. Chondro is cartilage. Calcinosis is calcification. On plain X-ray, bone appears white, as you all know. Air appears black. Cartilage also appears a little bit grayish black. So this is a plain X-ray of, we don't know which knee joint, yani, but we know it's the knee joint. This is the femur, and this is the tibia, okay? And if you look closely inside, the cavity of the knee joint should be black. But if you look closely, you will find a white line here, some white specks here, another white line here, and another white line here and there. So these are areas of calcified cartilage inside the knee joint, and this is what chondrocalcinosis is all about. Is it clear?
Yes.
Okay. And in secondary hyperparathyroidism, which occurs mainly in cases of chronic renal failure, we can see several types of metabolic bone disease. One of them is osteomalacia. Osteomalacia is the equivalent of rickets in adults. It occurs mainly due to decreased calcium absorption from the intestine. Okay? But this is a plain X-ray of the right hip joint. Of course, it is enlarged. This is the head of the femur, the neck, the greater trochanter, the lesser trochanter. This is the acetabulum. If you look closely at the neck here, at the arrow points at something that looks like a fissure fracture. But this is not a fissure fracture. This is the typical loser's zone in the inferior femoral neck. This is typical for osteomalacia. Okay? And again, we have another entity of metabolic bone disease in secondary hyperparathyroidism or in chronic renal failure called osteosclerosis. Yani the bone appears more sclerotic than usual. If the normal bone is white, then sclerotic bone appears more white than normal bone. So this is a plain X-ray of the lumbar spine of a patient with secondary hyperparathyroidism and osteosclerosis, showing what is known as rugger jersey spine. What is that? You notice the vertebral bodies are excessively white. In between are the intervertebral discs. They appear black. Okay, so the general appearance of this spine appears like the jersey of football, soccer player, or rugby players who used in the past to wear jerseys that were striped, white and black, white and red, not like nowadays with the different commercials on top, Vodafone, Coca-Cola, and so on. So this is the rugger jersey spine of osteosclerosis. Okay, any problem so far?
No.
Okay. And here you can see a plain X-ray of the lumbosacral spine of a patient with secondary hyperparathyroidism. Have you noticed patients who have chronic renal failure and secondary hyperparathyroidism? Did you notice how they walk? Did you notice their gait? Who can tell me? Have you seen any such patients before? Can you still hear me?
Yes, doctor, can hear you.
Type, where's the answer?
Oh,
Huh? You didn't see.
I didn't notice, no.
Type, you didn't notice. I will tell you. Next time you see a chronic renal failure patient, look closely how they walk. Most of them, if not all, they have a waddling gait. a Trendelenburg gait. Why is that? Because of two reasons. One reason is they have weak proximal muscles of the hip joint, namely the glutei. The glutei are responsible for what? If you raise, let's say if you raise the left foot from the ground, then the gluteus should contract on the left side to elevate the pelvis to prevent it from falling down, right? But here they have weak glutei. So what happens is when they lift the one leg from the floor, the hip on that side falls down. And then if they lift the other leg from the floor, the other side of the hip, instead of rising, it drops. So this way they walk like a duck, waddling gait, or it's also called Trendelenburg gait. Okay, but not only does this occur because they have weakness of the of the proximal muscles of the thigh due to hyperparathyroidism, secondary hyperparathyroidism. No, but because also they have a widened sacroiliac joint. So as if the sacroiliac joint is unstable. You see, normally the sacroiliac joint should appear as a mere line, just a line, an S-shaped line. But here you see as if it's widened. Huh? It's widened. The sacroiliac joints are wide, contributing to the instability of the gait of the patient. Is it clear?
Yes, doctor.
Okay. Now, coming to pathological fractures. The term pathological means that this fracture occurred in a pathological bone, a bone that is not healthy, because the patient will tell you, in order to fracture the neck of the femur, like here on this slide, the patient should have severe trauma, car accident or road traffic accident, whatever, fall from a height. But here in this case, the patient will tell you, I tripped over the bed mat, مشاية, كعبل في المشاية, and then he suffered this fracture, he or she, that is. So this is a plain X-ray of the right hip joint showing a pathological fracture. Here's the head of the femur, the acetabulum, the greater trochanter, the lesser trochanter, the shaft, but where's the neck? It's broken and it's compressed against the head, okay? So this is a pathological fracture. And not only that, this is another plain X-ray of the left femur of a patient with another pathological fracture. Here you notice that there is a well-marginated cortical lytic lesion, and if you look closely inside, there is endosteal scalloping. Yani this is a distal brown tumor in the left femur, okay? More proximal, there was a similar lesion and the patient was unlucky enough to have suffered a pathological fracture through this brown tumor, okay? And this is how it looks like after healing. This is the callus. Remember, for your pathology, a fracture heals by callus formation. Very nice healing in the proximal lesion, but the distal lesion is still there. You can still notice the endosteal scalloping, you see? Okay, so if the patient is unlucky, he or she, they will develop another pathological fracture through this distal brown tumor, okay? So this is how the lesion looked like, the pathological fracture before healing and after healing. But the distal brown tumor is still there. Okay? Any problems so far?
No.
All right. Now, remember when I told you nephrocalcinosis? Nephro is kidney. Calcinosis is calcium deposition. So this is a plain X-ray of the kidneys and urinary bladder, but mainly the kidneys. This is the last strip, okay? The last strip. And here you can see this is the renal angle. The kidney shadow is visible, you see? This is the kidney shadow. Here is the kidney shadow, but it's a bit concealed by gas in the colon, which appears black, okay? Type. So if you look closely inside the kidney, you will notice white specks of calcifications. You will tell me these are renal stones. No, these are areas of nephrocalcinosis, because renal stones would appear like rounded or oval-shaped, densely white objects inside the pelvic calyceal system, while the nephrocalcinosis is in the pyramids, at the tip of the pyramids, like I will show you on the ultrasound. Okay? Now coming to ultrasound in hyperparathyroidism. This is an abdominal ultrasound. This is posterior, this is anterior, and it appears conical because the transducer emits rays. You see, ultrasound rays, they are diverging like that. And at the interface of every, let me put the charger before it cuts off. Okay. Can you still see my slides?
Yes, doctor.
Okay, so I was telling you the rays, they are diverging like that, and at the interface of each tissue plane, they become either reflected back to the transducer or they traverse the different tissue planes until they reach the back. So here you will notice that there are some shadows, right? This is what we call acoustic shadow. This is here the right cupula of the diaphragm. This is the liver. So this is the right kidney cut longitudinally. And the white specks inside are the calcified pyramids, nephrocalcinosis. Why is there an acoustic shadow behind? Because, imagine you are standing under the sun at midday using an umbrella. Under the umbrella, there will be a shadow because the umbrella prevents the sun rays from reaching your body, right? Or reaching the ground underneath you. The same applies for ultrasound waves, okay? Ultrasound waves, if they meet a calcified area or a stone, they will not pass through, so there will be a shadow behind. So these are calcified pyramids with acoustic shadow behind. This is even a clearer ultrasound. The resolution is better. You can see here that here is the key. So this is a longitudinal ultrasound of the right kidney. Okay, this is the liver with the portal tracts, and this is the right kidney cut longitudinally, and these are the calcification, the nephrocalcinosis inside. Okay, type. Another transabdominal ultrasound here showing, you see, this is a border longitudinally cut kidney, and here they appear pyramidal in shape. You see, they are pyramidal. So these pyramidal shaped hyperechoic means hyperechoic means they are white in color. The density is more than the surrounding kidney. Okay, and giving acoustic shadows, this means that these are calcified pyramids. So this is how nephrocalcinosis looks like on ultrasound of the kidney. Okay. Now coming to renal stones. This is another abdominal ultrasound showing many renal stones. You see, these are the white objects here with the very dense acoustic shadow are the renal stones, and they are multiple. They are bilateral also, and they are recurrent. Okay, here the renal stones are inside the pelvic calyceal system, but there in nephrocalcinosis, the calcification was in the pyramids, in the tips of the. You see, the pelvic calyceal system, if you can see in my picture, pelvic calyceal system is like that. The stone would be here inside, but the nephrocalcinosis would be at the tips of the pyramids. Is it clear? Any problem so far?
Yes, doctor, it's clear.
Okay. Now, this is a neck ultrasound showing, this is the trachea, same anatomy. This is the isthmus. This is the right lobe of the thyroid. And here the arrows point at a hypoechoic with inhomogeneous, but hypoechoic. It means the echogenicity is not homogeneous, but still it is hypoechoic compared to the thyroid. And this is a parathyroid gland. Normal parathyroid glands, they are not visible on thyroid on neck ultrasound. Once they become visible, it means they are hyperplastic or there is an adenoma. Okay, a very important piece of information. And this is another ultrasound on the neck. Here's the trachea, here's the isthmus, here's the left thyroid lobe. You see it's the echogenicity, it appears a bit bright, and this is a parathyroid adenoma. It is hypoechoic compared to the thyroid. And here the same, this the trachea, the isthmus, the left lobe, the carotid artery, and this is the parathyroid adenoma, hypoechoic. Okay, is it clear? Any problem so far?
It's clear.
Okay. Now coming to CT scan in hyperparathyroidism. Remember when I told you brown tumor of the jaw or osteoclastoma? This is the other term. This is a CT, a coronal CT, cut like that, coronal CT of the skull showing an expanded bony lesion of the jaw. You see here. And if you look closely inside, there are attempts at, there is as if bone is eroded, but there are attempts of formation of bony septi. And of course, the teeth are also malaligned. Okay, just to show you the anatomy, this is the middle cranial fossa, and this is the nasal septum, the turbinates, the inferior turbinate. Okay, and this is the orbit. Okay, and here is the jaw starting to show the dilatation or the expansion of the bone with the on the right side with the deformed teeth. Okay, this is typical osteoclastoma of the jaw, and the patient usually complains of swelling, painless swelling of the jaw. It may also affect the floor of the mouth. And I've seen one patient who had a small osteoclastoma on the maxillary bone, but the CT looks the same. Okay? Right. Now coming to axial CT of the neck. Axial means it is cut transversely like that. Here is anterior, here is posterior, here is right, and here is left. Bone appears white, so this is the cervical vertebra. Okay? And air appears black, so this is the trachea. This is the thyroid gland, the isthmus, the right lobe and the left lobe. And here is a right parathyroid adenoma. Okay? We have less than 1 minute in this call, so I will stop the meeting and we will come again through the same link that I have sent you on the WhatsApp group. All right? Please don't be late.